Hello, and welcome to this program. Does SGLT2 inhibition have a role in the management of diabetes? I'm Vivian Fonseca, Professor of Medicine and Pharmacology and the Chief of the Section of Endocrinology at Tulane University Health Sciences Center in New Orleans, Louisiana. And joining me today is Dr. Cyrus D'Souza, who's Professor and Chief of the Division of Diabetes, Endocrinology, and Metabolism at the University of Nebraska Medical Center in Omaha, Nebraska. Welcome, Cyrus.
Thank you, Dr. Fonseca.
So, Cyrus, could you tell us a little bit about the physiology of renal handling of glucose and how that can be exploited to treat diabetes?
Thank you, Dr. Fonseca. I will review a few slides on the renal handling of glucose and why this is so important as a potential drug target. So in normal individuals, a large amount of glucose is filtered in the kidneys, approximately 180 grams per day. However, most of this is reabsorbed, and the urinary glucose excretion in a normal person is less than 0.5 grams per day. Glucose is usually reabsorbed in the proximal tubules by a co-transporter, which is called sodium glucose transporter, or SGLT. SGLT has two types, type 1 and type 2. SGLT1 is found in the kidneys as well as in the intestines. In the intestine, its main job is to actually absorb glucose or galactose, while SGLT2 is also found mainly in the kidneys, and it's more specific to glucose. SGLT2 has a low affinity for glucose, whereas the SGLT1 has a high affinity. Although the transporting ability for SGLT1 is low and the transporting ability of SGLT2 is high. The role of SGLT1 is really absorption of glucose and galactose from the intestine, from the diet, while the main role of SGLT2 is to reabsorb glucose after filtration in the kidney. So we see here a typical nephron, and we know that there is a certain amount of glucose that's filtered every day, up to about 180 grams a day. And then SGLT2 is the main transporter that actually reabsorbs 90% of glucose, while SGLT1 reabsorbs about 10% of the glucose. This slide goes a little bit into the actual mechanism in the tubular epithelial cells of the kidney. You can see in the first upper part is the cell which shows SGLT2 in yellow. The SGLT2 has a high capacity for transporting glucose but a low affinity. Both SGLT1 and SGLT2 are glucose-sodium cotransporters. So as you can see in this figure, SGLT2 transports glucose from the lumen along with sodium into the cell. Then within the cell, the glucose is actually transported by GLUT2 into the bloodstream. And this is helped by the sodium-potassium ATPase, which helps to cycle the sodium in and out of the cell. GLUT2 is the transporter for SGLT2, while for SGLT1 it is GLUT1. So this is how the tubule works. SGLT1, as I said, is a low capacity, high affinity transporter, and therefore transports about 10%, and SGLT2 is about 90%. So we do have an experiment in nature that tells us what would happen if there was less or no SGLT2. Fortunately, there is a syndrome called a familial renal glucosuria. It is autosomal recessive in nature, and it is a deficiency of SGLT2. It is characterized by a persistent urinary glucose excretion, although the plasma glucose concentration is actually normal. The amount of glucose that is excreted varies from a few grams to more than 100 grams per day. So this syndrome, the familial renal glucosuria, gives us an opportunity to observe what happens in terms of when SGLT2 is actually absent or blocked. In these patients, there is no evidence of any renal glomerular or tubular dysfunction. They're usually asymptomatic. They do not have hypoglycemia or hypovolemia. They live a normal lifespan, and the majority of patients actually have no clinical manifestations. For example, they do not have a high incidence of diabetes or renal failure or urinary tract infections. They are usually normal, and the renal histology and renal function are quite normal. So in this slide, we will be reviewing the renal glucose handling. In a normal person, there is a theoretical threshold of about 200 milligrams per deciliter of plasma blood glucose, that at which point there is excretion. So the glucose renal reabsorption takes place from, say, about 100 and then keeps going theoretically till about 200, after which there's excretion. However, this is not completely there is a splay at the top end and the bottom end. So the real threshold is actually 180 milligrams per deciliter. So if you have a glucose that is above 180 milligrams per deciliter, you have reached the tubular maximum reabsorption rate for that glomerulus, and you will excrete any further glucose that is present. That would be in a normal person instead of the theoretical 200. Now, in diabetes, in a person with diabetes, this dynamic is actually changed for the worse, in the sense the plasma glucose concentration that is needed to begin excretion of glucose is actually increased to about 240. And the reabsorption capacity is actually increased. So what actually happens is that the ability of the kidney to actually retain glucose is largely increased. So the tubular maximum of glucose reabsorption is highly increased in diabetes. This causes a worsening of the high blood sugar or the plasma glucose concentration. It prevents excess glucose from being excreted. We can see why this may be so. So if you look at the glucose transporter protein and activity in human renal proximal tubular cells from the urine of patients with type 2 diabetes, you will see that in type 2 diabetes there is a large increase in the expression of the protein. Also, the activity of the protein is many times that of a healthy person. So what that means is, if you look at its functionality, if you look at labeled glucose uptake, you will see that labeled glucose uptake in type 2 diabetes in the kidneys is far more than it would be in a healthy person. That's just to show that this causes an abnormality in diabetes in terms of reabsorption and excretion of glucose. So there are a lot of preclinical studies or studies in animal models that demonstrate what happens in type 1, type 2 diabetes in terms of SGLT2 expression and its function, as well as what happens when you actually block SGLT2 function. So in animal models of type 1 and type 2 diabetes, the maximum renal tubular reabsorptive capacity for glucose is increased. In human type 1 diabetes, this is the maximum reabsorptive capacity for glucose is increased. In type 2, we assume it is increased, but it has not been systematically examined. The mRNA expression of SGLT2 in renal tubular cells have also been shown to be increased, along with the increased absorption or reuptake of labeled glucose. So what does that mean? What are the implications in terms of SGLT2 function and glycemic control? So in a normal person, this is an adaptive response to conserve glucose because humans tend to conserve energy. But this becomes maladaptive in diabetes because you don't actually want to conserve the glucose because that would actually increase your plasma glucose concentration. But that is exactly what's happening in diabetes. The kidneys are reabsorbing more of the glucose than is necessary. Also, this ability is increased because the renal tubular maximum for glucose for the kidneys is increased in diabetes. So, coming to the SGLT inhibitor history, there is a molecule called fluorescein, which was the prototype for SGLT inhibition. It was actually first described a long while ago in the mid-19th century and was isolated from the root bark of the apple tree. For the last couple of decades, it has actually been used in the exploration of SGLT function and its effects. Though it has some problems with it, it has low selectivity for SGLT2, which is the one that we are most concerned about, over SGLT1. And therefore, it would have GI side effects. The other problem with it has poor bioavailability, and because it's hydrolyzed in the intestine. That's why it's a good model to test cells, but not a good model to be used as a drug in a human. So there were a couple of experiments done in animal models. We're going to go through some of that. In this slide, we see that rats were treated with fluorescein. Either they were sham-operated controls. So in this experiment, rats were either 90% of their pancreas was taken out to induce diabetes. They were either given fluorescein or not. And you can see in group 1, which is the rats that were given a sham operation, but the pancreas was still intact. Group 2 is a pancreatectomy, 90% of the pancreas taken out. Group 3 is the pancreatectomy, 90% taken out, along with fluorescein. Group 4 is the sham-operated rats with just fluorescein without the pancreatectomy. And group 5 is the pancreatectomy rats with fluorescein once fluorescein is discontinued. The first row is looking at fasting plasma glucose, and the second row is the fed state, or the prandial glucose. So as you can see, if you infer from this, you can see that fluorescein actually lowers the fasting plasma glucose to almost the levels of the control group, which is group 1. So group 3 is almost similar to group 1. Also, it controls, so when you remove the fluorescein from treatment, it goes back up towards the group with pancreatectomy, which is group 2. So group 5 has a higher glucose level, 113. So similarly, it has similar effects on postprandial glucose. So you can see the control is group 1, and then the treated is group 3, and it's approaching 171. If you remove the treatment, it worsens to 306. So it does have a good effect on both, and that's what this slide shows. In this slide, we're going to look at ZTF rats, which are actually a model of type 2 diabetes, and chronic SGLT2 inhibition in those rats. Hyperinsulinic euglycemic clamp was done in these rats after administration of an SGLT2 inhibitor called T1095, which was administered with the diet for 4 weeks. So they noticed in the study that insulin action was improved as evidenced by a decreased hepatic glucose production, an increased hepatic glucose uptake, and an improved glucokinase and G6P ratio, which shows that actually the mechanism by which this glucose is being lowered could be more than just excretion of glucose from the kidneys. In this slide, dapagliflozin was shown to improve islet insulin content in the same ZTF rats, which are the type 2 diabetic model. The female rats were used in this because the female rats have a more gradual onset of type 2 diabetes, DAPA 1 milligram per kg body weight per day was administered orally for 33 days, and it improved the insulin sensitivity index. The insulin sensitivity index is an index which tells us how the beta cell is functioning. So beta cell function is measured by that. So there was an improvement in beta cell function. And they looked at the beta cell mass itself histologically, and there was a markedly reduced variability with the islets, and the morphology index was maintained at a level similar to the lean non-diabetic controls. This shows you that, again, the full effect of SGLT2 inhibition may not be only due to glucose excretion from the kidney, but may also have beta cell preservation type of effects. This is another study where obese rats were used, and in this model they're not genetically diabetic, but they were diet-induced obese rats. SGLT2 inhibition was done with dapagliflozin. What was noticed was there was an increased intake of water, increased urine excretion, and total urine glucose, which is expected. The consumed calories was increased by 12% versus the vehicle-treated animals, meaning the controls. Although they actually consumed more calories, these animals actually lost weight, about 4 to 6%. And if you compare them to the vehicle group, they actually lost 10%. It also showed increased utilization of fat as an alternate energy to glucose. And this was done by a method called indirect calorimetry and plasma ketone data. It also showed that the fasting serum glucose concentration was decreased by 64% at the 5 milligram per kg body dose on the 27th day of the study. So, in summary, this slide shows that there are several metabolic effects of SGLT2 inhibition that may or may not be directly related to just excretion of glucose in the kidneys. So what are the desirable properties of an SGLT2 inhibitor? They should be high potency, and they should have high potency and selectivity for the SGLT2 molecule, resulting in a good efficiency in the treatment of diabetes. They should have metabolic stability and shouldn't be broken down very easily. They should be absorbed easily and have good oral bioavailability, and therefore have convenient dosing schedules for better compliance. They should be tolerated well with minimal side effects, and they should be suitable for use in combination with other anti-diabetic drugs that are in current use. So selective SGLT2 inhibitors, the potential advantages of them would be that they minimize GI side effects, because as you were shown before, the SGLT1 is the main protein that is present in the intestine. So if SGLT2 is inhibited specifically, you're going to target the kidneys rather than the intestines, which will then result in less GI side effects. There could be unique potential for negative energy balance, which we saw in the animal studies. They could, the effect could be that you could correct glucose toxicity and maybe improve insulin action and secretion, as shown in the animal models. So those could be the potential benefits of SGLT2 inhibition. In this slide, we're going to show what SGLT2 inhibition does to renal glucose handling. So we have the plasma glucose going from 100 to 400, and then we have the urinary glucose excretion from 0 to 150. So as you can see, normally what happens is the normal threshold is 180 milligrams per deciliter of plasma glucose, above which there is excretion of glucose through the urine. The diabetes threshold is, as we reviewed before, increased to about 240. So the excretion takes place only above 240. Now what SGLT inhibition does is shift this curve of excretion leftward, so that excretion could begin as low as 100 milligrams per deciliter of glucose. So inhibition would shift the whole curve to the left. And so excretion occurs at an earlier plasma level and reabsorption is much less.
Thank you, Saras. Thank you very much for that discussion on the background about SGLT2 inhibition moving the renal threshold downwards, leading to glycosuria. This has been recognized, as you pointed out, for a while and has led to the development of a number of drugs that inhibit SGLT2. Some of these have recently received approval. Canagliflozin and dapagliflozin have been approved and are on the market in the United States, and an FDA submission has been made for empagliflozin, and we await their decision. Empagliflozin has been approved in Japan, and there are several other drugs undergoing such development. The next slide looks at the selectivity for SGLT1 and SGLT2, and as you can see, fluorescein is not selective at all, and that may have led to some of its side effects. And its IC50 is also somewhat low, and as a result, choosing drugs that are much more potent and more specific might make a big difference. There's some structural differences as well between the drugs that have been approved and those that have not. So I'm now going to talk about data from clinical trials on the clinical efficacy with the SGLT2 inhibitors that have been published on canagliflozin, dapagliflozin, empagliflozin, and epragliflozin. There is a lot of similarity between the data. The study designs are very similar, so the results, while not identical, are sort of similar. So I will go through some of them in a little bit more detail and then rapidly go over the rest to demonstrate to you that there is probably not a big difference between the clinical efficacy of these various agents. Canagliflozin was the first of these agents to be approved in the United States, and clinical trials demonstrated that as monotherapy, canagliflozin 100 milligrams lowered A1C over a 6-month period by about 0.9%. And the higher dose of 300 milligrams lowered it by 1.16%. Most of this reduction occurred within 12 weeks, and there was progressive reduction in A1C after that. The next slide shows the proportion of subjects reaching an A1C goal at 26 weeks was much higher at 300 milligrams of canagliflozin. If your goal is less than 7%, over 60% of patients met that goal, whereas only 20% of those on placebo achieved that goal. Now, these studies included some assessment of other parameters as secondary endpoints, including fasting glucose, which fell about 35 milligrams per deciliter at the higher dose of canagliflozin, with a difference from placebo of about 43. And these differences and reductions were apparent within a few weeks of starting therapy. And in fact, there's some data to show that glycosuria starts almost immediately, within a few days of starting therapy. Glucose excursion is higher following a meal, and therefore it would be interesting to see if you got a greater reduction with this class of agent in the postprandial phase. And the next slide shows that canagliflozin lowered postprandial glucose after a standard meal by almost 60 milligrams per deciliter, whereas with placebo there was a rise, which was only relatively small, of 5 milligrams. So that is monotherapy. It demonstrates the true efficacy of the drug compared to placebo. But of course, in clinical practice, we make comparisons with other drugs and often add on to other therapies, particularly metformin, which forms the cornerstone of therapy and is the first-line therapy in most patients. Therefore, let's look at adding on canagliflozin to metformin in the next slide. And over a 12-week period, the highest dose of canagliflozin lowered A1C by 0.95%, with a reduction in fasting glucose of 23, and interestingly, a reduction in body weight of 3.4 kilograms. In contrast, there was very little drop of 0.2 in the A1C with placebo. Fasting glucose went up a little bit, and body weight dropped very little. In this study, a comparison was made with sitagliptin, which is also often added on to metformin, and the lowering of A1C was 0.74, which is less than what was seen with canagliflozin. There was very little reduction in fasting glucose and very little reduction in body weight. So it seems from this that canagliflozin was certainly better than placebo and maybe better than sitagliptin in terms of reducing A1C, fasting glucose, and also causing some degree of weight loss, which could be an advantage in obese patients with type 2 diabetes. Next slide shows the change in A1C in a subset of patients who have stage 3 chronic kidney disease. This is very important when you're targeting the kidney because when you block reabsorption, you first have to have the glucose filtered. And as your kidney disease advances, there's less and less filtration, so there's less of reabsorption going to occur, and therefore blocking reabsorption is going to have less efficacy. And this is exactly what happened. Data were taken from patients who had a GFR of 30 to 60, and the reduction in A1C with canagliflozin was modest compared to what we saw earlier. When you broke it down, again, there was a difference between those who had an eGFR of 45 to 60, where the reduction was 0.52, as compared to those who have an eGFR of 30 to 45, where the reduction in A1C is very modest, even at the high dose, and is only 0.39. So based on this, there's some recommendations in the package insert to not use canagliflozin in patients who have a GFR at baseline that is persistently less than 45. In order to avoid dehydration, it's recommended that patients who have a GFR of 45 to 60 use only the 100 milligrams and don't up-titrate to 300 milligrams. Similar data have been obtained with the other SGLT2 inhibitors, and in fact, the efficacy of dapagliflozin with an eGFR less than 60 is not very strong, and according to the package insert, that drug should only be used in patients who have an eGFR greater than 60. Here's an example on the next slide of what is in a package insert on dosage and administration. Canagliflozin is recommended in a starting dose of 100 milligrams once a day, taken before the first meal of the day. And then the dose can be titrated upwards as the patient tolerates it well and needs further reduction in glucose or A1C from 100 to 300 milligrams. In those, as I mentioned, those who have a GFR 45 to 60, limit the dose to 100 milligrams and don't start treatment with this drug if the GFR is below 45, or if it falls to below 45 for any reason, canagliflozin should be discontinued. The next slide looks at the effect on dapagliflozin, and this more or less illustrates what was seen, what you saw with Dr. D'Souza's slide, where in type 2 diabetes, excretion of glucose is a little bit lower because the renal threshold has been moved up, although you do get glycosuria because the blood sugar in some patients is so high. And there's a substantial reduction, usually to the 70 to 90 milligram per deciliter range, but in some people can go even lower than that. With dapagliflozin, there's again a dose-response relationship with a reduction in A1C over 12 weeks of about 0.8%, a reduction in fasting glucose, as well in the range of about 20 to 30, and a reduction in body weight of about 3 kilograms. This study with dapagliflozin compared it with metformin, where you got similar reductions in A1C, slightly lower reduction in fasting glucose, and somewhat more modest reduction in body weight. Postprandial glucose in this study was assessed and presented on the next slide, where it's presented as area under the curve, so the figures may not be very meaningful because we don't often think about it in that particular way. And you see again a substantial reduction in postprandial glucose excursion. And this was accompanied by an increase in mean urinary glucose. They actually measured 24-hour urine glucose in these studies and corrected it for creatinine. And you see an increase in urine glucose with dapagliflozin and no change with placebo or metformin. This, first of all, confirms the mechanism of action that we have been talking about, that this class of drug increases glucose excretion, but it has other explanations. All this glucose in the urine contains calories, so it may be the mechanism responsible for the weight loss that is seen with this class of agent. The next slide looks at dapagliflozin as initial combination therapy for people who have not been on treatment and added on to metformin slow release. Dapagliflozin 10 milligrams alone led to a reduction from baseline of 1.45 milligram. Remember, these are treatment-naive patients. They've never had treatment, and they tend to have a very good response, and they got a similarly good response with metformin, a reduction of 1.4, and the combination led to a reduction of 1.98%. I'll now go through a range of studies on one slide, and the next slide shows dapagliflozin over 24 weeks as monotherapy, metformin combination, add on to sulfonylurea, add on to pioglitazone, and add on to insulin. And what you see is a consistent reduction in A1C, more or less similar in each of these background therapies with 2.55 and 10 milligram doses of dapagliflozin. And those are the doses that are available. The patients can be started even on 10 milligrams a day in clinical practice. If you look at fasting glucose from all those studies on the next slide, you see a similar reduction in fasting glucose in a dose-responsive manner. The change in hemoglobin A1C as well as other parameters was studied in a trial comparing either dapagliflozin or sulfonylurea added on to metformin. With a baseline A1C of about 7.7%, the reduction in A1C at 1 year was minus 0.52 with both dapagliflozin or glipizide added on to metformin. This seems somewhat modest compared to the other studies we have discussed earlier, but the baseline A1C was lower, and the reduction in A1C is often related to baseline A1C. However, it's not just A1C alone we should be looking at, and when we compare the rates of hypoglycemia between dapagliflozin and glipizide added on to metformin, it is substantially higher with glipizide as compared to dapagliflozin. Also, there is weight loss with dapagliflozin added on to metformin, and either weight gain or no change in weight with glipizide added on to metformin over 1 year. And so if you take the overall composite, one can argue that there is a difference in how you lower A1C with one combination lowering it to the same degree as the other without hypoglycemia and some weight loss. Next slide looks at a further longer-term follow-up showing, again, a reduction with both drugs, but the effect seems to have waned a little bit. The next slide looks at a weight loss with dapagliflozin added on to metformin with baseline BMI of 31, and you see a reduction in body weight of 2 kilograms. There's a reduction in waist circumference, reduction in fat mass seen on DEXA, visceral adipose tissue by MRI, as well as subcutaneous adipose tissue. So there's a generalized loss of weight and loss of fat, which may be an advantage in some patients with diabetes. This slide looks at a range of phase 3 studies and looks at the weight loss. And what is interesting about this slide is that if you look at the patients treated with insulin, both over 6 months and over 1 year, there is a loss of weight, which is very difficult to achieve as you improve glycemic control in patients on insulin. Now, another effect that has been noted with SGLT2 inhibitors is a reduction in blood pressure. These drugs are not approved as antihypertensive agents, but they seem to have a consistent effect on blood pressure lowering across all drugs in the class and all clinical trials. On this slide, you see that either as monotherapy, added on to metformin, or added on to sulfonylurea, you get a reduction in blood pressure of about 4 to 5 millimeters of mercury systolic and about 2 millimeters of mercury diastolic. Now, maybe perhaps to counter that is a change in lipids that gives you mixed results, and that has been seen again with several drugs in this class. The next slide shows plasma lipid changes in data from a number of dapagliflozin studies. And to look at the middle column, which is the dapagliflozin 10 milligrams, you see a small increase in total cholesterol, a 2.7%, a relatively small increase in LDL cholesterol, and also an increase in HDL cholesterol with a small fall in triglycerides, which may be related to weight loss. Here's a summary of the package insert dosage and administration instructions from dapagliflozin. It's recommended that they start with 5 milligrams daily, taken in with or without food in the morning, and the dose can be increased up to 10 milligrams daily. You should assess renal function prior to initiation, and do not initiate if the eGFR is less than 60. And if it falls for any reason on treatment to below 60, the drug should be discontinued. Empagliflozin is not yet approved in the United States, but here is some data on it. Reductions in fasting glucose and A1C, which appear slightly less than what we've seen with the other agents, but that may just reflect a different population and a different baseline A1C, and there's no head-to-head data available. What is obvious is that there's a consistent reduction in and a dose-response relationship in terms of A1C lowering, fasting glucose lowering, as well as weight loss. This looks at empagliflozin, various doses added on to metformin, showing a further reduction in A1C, fasting glucose, and body weight. And the next slide looks at data on empagliflozin monotherapy and shows a reduction in A1C and more patients meeting the A1C goal of less than 7% on the highest dose of empagliflozin, very comparable to metformin. Next slide shows weight loss with empagliflozin with no change in weight with metformin over 12 weeks. This slide shows, again, adding on to metformin, a reduction in A1C, fasting glucose, and body weight. So let me now turn to the adverse events with SGLT2 inhibitors. The next slide looks at adverse events. Genital and urinary tract infections have been some degree of focus in data collection with these trials because you're putting so much glucose into the urinary tract. Also, because you're causing excretion of glucose, you may have diuresis, and so people have looked at hypotension, hypovolemia, dehydration carefully. There have been liver function tests looked at, and cardiovascular effects are of interest in all diabetes studies. So let's look at these individually from various trials. Here is the incidence of vulvovaginal candidiasis in female patients treated with canagliflozin and compared with placebo and sitagliptin, which both the latter two are equal, being about 3%, whereas it was significantly more at 10.4% with canagliflozin. And this has been looked at in another trial and presented at the FDA on the rates of genital infections and urinary tract infections with dapagliflozin. The increase in urinary tract infections compared to placebo is actually quite small, whereas the major increase appears to be in terms of genital mycotic infections. In men, the rates of these infections are much lower. You see that there is virtually no increase in urinary tract infections in men, but there is still an increase in genital infections with dapagliflozin. Similar results have been presented with empagliflozin increase compared to placebo, and certainly an increase compared to sitagliptin as well, of genital infections, but very little increase with urinary tract infections. A comparison has been made with metformin in terms of genital infections with all these drugs. And year 2, on the next slide, you see that it's much higher with SGLT2 inhibition compared to the comparator metformin. It appears that in general, these genital infections are mild to moderate. They resolve with conventional intervention. The investigators were left to do whatever they would normally do if a patient presented with myocardial infection, and they rarely led to discontinuations from the study. A key question, though, is does that lead to an increase in true urinary tract infections, particularly upper urinary tract infections such as pyelonephritis? This slide shows the rate of urinary tract infections in patients treated with SGLT2 inhibitors in combination with metformin. And the comparators were either placebo or glimepiride, depending on the study. And the data here is summarized with dapagliflozin, canagliflozin, and empagliflozin with different durations. The rate of urinary tract infection with the combination of SGLT2 inhibitors and metformin was very similar to that of the combination of metformin with either placebo or glimepiride, with perhaps a small increase in this rate in some of the studies. So to summarize urinary tract infections, the occurrence of signs and symptoms were very similar across all the treatments. They were generally mild and not recurrent, and they responded to standard treatments and rarely led to discontinuation. What about volume-related side effects? And this slide shows data presented with dapagliflozin, and compared to placebo, the total number of subjects with the volume-related events was higher, but it was fortunately relatively uncommon. It was 0.8% with the highest dose of dapagliflozin and 0.4% with placebo. Most of this related to a drop in blood pressure, so there was some degree of hypotension. There were a few cases, but very little of syncope. One patient on the high dose and 3 on the lower dose had dehydration. And orthostatic hypotension was seen in a few patients. Most of these patients were on diuretics, particularly loop diuretics, and it may be possible to make adjustments in the doses of these medications. In many diabetes medications, we are interested in changes that may occur with the liver. The next slide looks at liver function test abnormalities with dapagliflozin and controls, and there does not appear to be any difference between those. Now, cardiovascular outcome trials are important. Cardiovascular events are important in diabetes. These medications have met the criteria for approval in not having excess cardiovascular events in the phase 3 trials, which were not designed as cardiovascular outcome trials, but still had enough events to demonstrate some degree of safety. However, as per the FDA mandate, they're required to do long-term adjudicated cardiovascular outcome trials, and these are ongoing with canagliflozin, dapagliflozin, and empagliflozin, recruiting a large number of patients with cardiovascular disease and diabetes. And the primary outcome here is very similar in all of them, including cardiovascular death, non-fatal MI, and stroke. And it'll be a few years before we get the results on these trials, and we await them to hopefully demonstrate safety of these agents. So in conclusion, there are many advantages and some concerns with SGLT2 inhibitors that we have discussed. They are easy to administer once a day in tablet form. They lower fasting, postprandial glucose, and A1C. They cause weight loss, and some of that may be related to the 60 grams of urine, the glucose, which is 240 calories, which could lead to half a pound of weight loss. They do not increase hypoglycemia by themselves. There's a modest blood pressure lowering. They work in combination with a wide variety of agents, including insulin, because their action is independent of insulin secretion or resistance. And we don't know whether they will be useful in other patients, and we hope we'll see trials in patients with type 1 diabetes or pre-diabetes, but as of right now, they're not approved for those indications. There are, of course, concerns with any new drug and unknown side effects. There were concerns about bacterial urinary tract infection, which has, from the trial data, does not appear to be greatly increased. However, fungal genital infections have clearly increased, but they seem to respond to standard therapy, and we need to educate our patients about this and treat them promptly. They're certainly not as effective as in patients with renal impairment as compared to patients who have normal renal function. So renal function needs to be monitored. And because there's a transient initial period of dehydration, patients should be warned about that and their blood pressure monitored, and maybe some monitoring of renal function as well. We don't know about long-term safety effects, particularly on the kidney and cardiovascular outcomes, and those are being tested in long-term clinical trials. And of course, there's a concern about the rising costs of diabetes, but that is true of any one agent. So once again, in summary, good efficacy in lowering A1C, no risk of hypoglycemia, with some weight loss and blood pressure lowering, very easy to use as oral therapy, and can be given with in a wide range of patients with type 2 diabetes, irrespective of what treatment they're on. Let us now discuss a case where this principle of SGLT2 inhibition can be applied in practice. A 65-year-old African-American male was diagnosed with type 2 diabetes 10 years ago and has tried a variety of oral agents. He was on pioglitazone, glimepiride, metformin, and a year ago he had a myocardial infarction and the pioglitazone was stopped, and he was started on insulin with metformin and glimepiride continued. Unfortunately, he gained about 10 pounds in weight and had a few episodes of mild hypoglycemia over the past year. On examination, he has a BMI of 33.9 and a blood pressure of 125/75. On testing, he has a fasting glucose of 130, a 2-hour glucose of 210, and an A1C of 9.2. His LDL is 68, HDL 41, triglyceride 151. His creatinine is 1.3 with an eGFR of 52. He currently takes metformin 1,000 twice a day, glimepiride 4 twice a day, glargine 55 at bedtime, takes an aspirin, losartan, amlodipine for his blood pressure. He also takes metoprolol and atorvastatin at 80 milligrams a day. Cyrus, what would the goal for a patient like this be with comorbidities and a previous MI? Would you choose 6.5, 7, 7.5? What would you choose?
So in this patient, we would refer to the guidelines published by the ADA first in 2012, along with the EASD. And in those guidelines, we would incline us to choose less than 8. The guidelines, in brief, related to the individualization of A1C goals depending on the patient's comorbidities and social situation. So, for example, if a patient had a lot of cardiovascular morbidity and they had a long duration of diabetes, had a propensity to hypoglycemia, and had a duration of diabetes more than 15 years, you would tend to have a goal which is closer to 8 than lower. On the other hand, if a patient had a new onset of diabetes, had no other complications, then and had a good understanding of the disease, that patient might have a much lower A1C goal than this particular patient. So for this patient, because he has already had acute myocardial infarction, he does have a mild degree of chronic renal disease, and therefore a goal of less than 8 would be good for him.
So how would you achieve that? He's at 9.2. Would you go up on his insulin, add another insulin, a GLP-1, DPP-4, or just leave him alone? What would he do?
In this scenario, since his insulin has been titrated up to 55 units of insulin glargine. If you were to go the insulin route, you would have to probably add a short-acting insulin, which would then predispose to more hypoglycemia, and also he would have to take many more shots a day. So the alternative might be to actually add a GLP-1 agonist to this patient, which would lower the requirements of the insulin, as well as help the patient maybe lose some weight in the long run.
Yeah, I would agree with that. You want to avoid something that's going to increase hypoglycemia and weight gain, which he's been struggling with. He's had both those problems, and so I would avoid going up on the insulin immediately. In fact, what happened with him was liraglutide was added, 0.6 milligrams. It was up-titrated. Insulin glargine was reduced, but then was up-titrated back up to 60. And when he came back for follow-up, his A1C had come down a bit, but was still 8.3%. So what would you do next? Would you add a DPP-4 inhibitor, or add more insulin, go up more on the insulin, or add an SGLT2, or just leave him where he is and be happy with 8.5?
As I was mentioning before, for this patient, insulin would be a big step, short-acting insulin, along with the weight gain and increased hypoglycemia. A possible alternative would be to add the SGLT2 inhibitor. In this scenario, we cannot actually use DPP-4s because they kind of have a similar mechanism to GLP-1s. And so ideally, SGLT2 inhibition would be a different mechanism, being the excretion of glucose to help with the glycemic control.
Of course, there's the problem of the cost of so many medications and 2 new medications that cost a lot. But fortunately, we were able to get approval from his insurance to pay for an SGLT2 inhibitor, which was added. And as a precaution to avoid hypoglycemia, we reduced his insulin dose to 40 and then titrated back very slowly. He's back up to 60, but his A1C now is 7.4. He's not getting hypoglycemia, and he's lost a further 3 pounds in weight. So overall, he's sort of well within the goals that you set for him. And you could even consider, some people may choose 7.5. So even for that goal, he's meeting it at 7.4. He's obviously got a complex regimen, but he's controlling his weight and not getting hypoglycemia, which is desirable. So thank you very much for your insight into that patient. It demonstrates the added tool of SGLT2 inhibition in addition to multiple other therapies because of its unique mechanism of action that is possible and improves glycemic control while causing some weight loss. Thank you.